We're pleased to introduce our speaker today. It's one of our own, Dr. Vineet Chopra. Many of you know very well. So let me tell you what you may or may not know about Vineet. Actually, nothing in the closets here. But so Vineet graduated with his MBBS from Grant Medical College in Mumbai, India. And later on, during his transfer and training here, got his Master of Science in Health and Health Services Research through our Robert Wood Johnson's Clinical Scholars Program curriculum here at the University of Michigan. After his medical degree, he did his internship and residency at the VA in the Bronx, and he was later also chief medical resident there. He then subsequently spent some time in Arkansas, and we were fortunate to get him up here to the University of Michigan thereafter. Vineet is currently an associate professor on the tenure track here at the University of Michigan, and he was appointed chief of the Division of Hospital Medicine in July of 2017. He's also the co-director of the Patient Safety Enhancement Program at the Ann Arbor VA and co-director of the Integrated Research Unit here between hospital medicine and general medicine at the University of Michigan. His work has focused on patient safety and hospital-acquired infections, particularly peripherally inserted catheters. He has published in his relatively young career over 190 publications. He's been well-funded through both in NIH and AHRQ mechanisms. But reminiscent of what you just heard about our students, a few years ago, Vineet was the triumphant awardee for several awards, and I think he was carrying so many bags that we had to give help because he had won all the awards that evening. And so just to mention, so this was back in 2016. He received the H. Marvin Pollard Award for Outstanding Teaching of Residents. That was one plaque. And then at the same time, he won the Jerome Kahn Award for Excellence in Research. This is our top research award for developing junior faculty. And he also, that year, won the Kaiser Permanente Award for Excellence in Clinical Teaching and the Richard D. Judge Award for Medical Student Teaching. So I think it was 4 bags you were carrying at least at that time. Also, Vineet was recently awarded last year for the Gold Humanism Award, and that's usually given to a faculty who is probably more pretty chill than aggressive in academia, but it just tells you a lot about Vineet. He's a go-getter, gets things done, not only as a hospital medicine division chief, but also in his research, but he's also relatively down-to-earth and practical, and I think those types of awards reflect that in his own personality and achievements. So it's my pleasure to have Vineet talk us today about Rethinking Vascular Access, the case for and against PICC lines. It's always a pleasure to have you here, so welcome again, Vineet.
Thank you, John.
And thank you for doing Grand Rounds today.
Thank you, John. It's a pleasure. Thank you. Dr. Carruthers is very kind, and I will give him $20 after this for that introduction. Good afternoon. Welcome to Grand Rounds. The last time I did this was almost 7 years ago when I was starting my research career. It's been a while. But I'm delighted to come back to talk to you about what I've been thinking about, which is this concept of vascular access with a real emphasis on peripherally inserted central catheters, or PICCs. Before I start, I want to acknowledge this is an unusual Grand Rounds. We have radiologists in the room, we have some surgeons in the room, and we have the vascular access team in the room. And it's just an example, I think, of what an incredible place Michigan is to be so collaborative to do this kind of work as well. Here are my financial disclosures. I've received funding from a number of agencies, as Dr. Carruthers mentioned. I've also received honoraria as an invited speaker for CME research, and I am a proud employee of U of M and the VA Ann Arbor. And the views I express today represent my views, not those of my employer, as I'm supposed to tell you. I'm going to start with a clinical case, a true case that I was asked to see many years ago when I was starting my work in this space. This is a patient in our surgical ICU, a 68-year-old male with the usual medical comorbidities, diabetes, hypertension, hyperlipidemia, a new diagnosis of pancreatic cancer. He was in our ICU after a Whipple's procedure. So many of you know this is a pretty extensive abdominal procedure. He had his stomach removed, duodenum removed, a lot of lymph node resection. He was actually post-op day 3 or 4. I was called to see him for something the surgeons call medical management, which I have yet to figure out what that means. But I'm going through his chart, trying to figure out what's going on. I'm seeing he's on an IV insulin drip. He's on TPN because he's not eating, and he's also getting broad-spectrum IV antibiotic therapy. So here I am looking at this, and I got a tap on the shoulder, and it's a surgical ICU fellow, and he says, "Hey, aren't you the guy that does all that PICC work?" I said, "Yeah, that's me." He says, "Maybe you can help us. What central venous access is best for this patient given his needs?" So it got me thinking, if I were to design a wish list of the ideal central venous catheter for this patient and for any other patient, what would that wish list look like? Here's my wish list for the ideal properties of central venous catheters. First and foremost, they got to be easy to insert, right? So for those of you who place these lines, you know this is sometimes the biggest barrier to putting them in. So the ideal catheter should have a low threshold to actually putting them in safely. Speaking of safety, they should ideally be free of complications. And when I think of complications, I think of the two most lethal and the most comorbid ones, infection and blood clots. Third, these devices are increasingly being used to move patients outside of the hospital. So the ideal device should be self-care compatible. Patients should be able to care for them when they leave the hospital. We're in a cost-conscious era, folks, so the ideal device can't break the bank, right? We've got to put this in a way that actually makes economic sense. And last but not least, they have to last, right? They have to be durable to last for the indication that you need them to sort of be in for. Now, when you go looking for a device that meets all of these criteria, you get a very funny message. We're in an era where we can do double lung transplants and stem cell transplants, but we still don't have a central venous catheter that actually meets all of these criteria. That's where this man comes in, a guy called Dr. Vron Hochal. Some of you may have heard of him, some of you may not. He actually is a U of M trained surgeon, the class of 1964, still in practice, actually works at St. Joe's as a GI surgeon. And Dr. Hochal in the early 70s got very frustrated having his patients be in the hospital after these big GI procedures only to get TPN. So they were there after their procedure and they were exposed to all kinds of complications because they were still in the hospital getting this nutrition that they so badly needed. So he became interested in what he called developing an outpatient catheter for TPN, something that the patient could actually use when they went home. And he recognized this had three main requirements. It had to be easy to insert. His patients were coming out of the OR. He didn't want to take them back there after all of the stuff they've gone through. It had to be self-care compatible, right? The patient had to go home with them, and it had to be durable. It had to last. In May of 1975, Hochal published this paper in then what was called the Archives of Surgery, or JAMA Surgery, where he described total intravenous nutrition with peripherally inserted silicone elastomer central venous catheters. That's a mouthful. Let me tell you what he did. Hochal designed this unit, something he called the crank introducer unit. And just a word to the wise, if you're an entrepreneur, that's not a good name for a device. I highly recommend you don't use the word crank in it. But what Hochal did was he actually had a hollow needle with a guide wire over this thing that he called a drum kit, and he would palpate the vein of an upper extremity, pierce the vein with the needle, put his two fingers in those two holes, and thread a catheter from the peripheral vein to the central circulation. Pretty cool, right? What's even cooler was that he actually did this. So he inserted 36 catheters using this methodology. The mean dwell time was 20.4 days for these devices. You may think that's not a big deal. Keep in mind in these days it was 7 days or so for a central line if you were lucky, versus a Hickman or a Broviac, which you had to go back to the OR for. So this was really a difference in terms of what they were getting. 30 of the 36 catheters lasted the entire duration, but 6, about 20%, developed infection and phlebitis. And what I will tell you today about what Hochal did not know now is this was the first ever report of the modern peripherally inserted central catheter, also known as the PICC. We've come a long way since Dr. Hochal's first report, right? Today, PICCs are available in all shapes, sizes, configurations, coatings. We even have the specialized workforce right here, vascular access nurses, who do this at the bedside to actually get patients what they need in a timely fashion. But the question for you, when you think about my ideal list of properties for central venous catheters, is how do PICCs stack up? What do we know about these devices in terms of evidence? So for today, for Grand Rounds, what I thought I would do is go through a few of these, specifically the question of ease of insertion and complications, and do for you what we do well at Michigan. We compete, right? So I'm going to give you a scorecard. The evidence as it stacks up for PICCs versus non-PICC central venous catheters. I'm talking about all the other catheters except for dialysis. We're not going there. And I'm going to show you some evidence around ease of insertion, thrombosis, and infection as it applies to PICCs and other central lines. Sound reasonable? Let's do it. Let's talk about ease of insertion first. Most of you know this, but this is the key advantage of why PICCs are being used so often today, right? Compared to other central lines, they are actually quite easy to insert. In adults, we place them above the elbow in the veins of the upper extremity, and as a consequence of this site and this route, not only are they easy to insert, they're also safe to insert. So where do we put them in adults? Typically, it's the brachial and the basilic veins of the upper arms. Those are the largest veins. Sometimes the cephalic veins, if they're large enough. And by using this site, we avoid the big three complications. We avoid trauma to the vessels of the neck and the chest, right? We avoid that dreaded complication, pneumothorax, which when I was a resident, I learned if you haven't had a pneumo, you just haven't placed enough lines yet, Chopra. Give it a few more years, it'll happen, right? And bleeding, right? Bleeding, when it happens with a PICC, is easy to control. You put pressure at the site. How many of you have actually hit the carotid artery or the subclavian vein putting lines in? It's very hard to stop the bleeding there, right? Because there's nothing to compress against. So people believe that the site of insertion is what gives the PICC safety. This is only part of the story. It's not just about the site. Just like central lines, ultrasound is the key to safety with PICCs. So ultrasound guidance has been associated with fewer earlier and later complications than the way Hochal did it, the blind way, the palpatory way. It increases your time to venous access. That makes sense, right? Because you can see where you're going. It also reduces costs because you're spending less time at the bedside. You're actually able to map and track your needle to the vein. Ultrasound, though, is really useful because it allows you to do something else. This concept of mapping the veins of the arm. With ultrasound, you can actually look at the venous capacity of the arm. Do they have plump, big vessels, right? Things that are all open and available? Or is that single vein left over that you really probably shouldn't want to touch at that point in time? It allows you to look at something important in terms of the catheter size. We'll talk about this in a second. This is one of the key safety measures when it comes to PICCs, is the size of the catheter in relation to the size of the vein. And last but not least, it allows you to figure out what the ideal site of puncture is. Veins have these things called valves. They can be dilated and tortuous. With ultrasound, you can see them. You probably don't want to go anywhere near them if you're going to thread a catheter through, and ultrasound lets you look and see where you're going. That makes sense. Let me show you some data that actually makes this point valid. This is a RCT from China, 240 patients, all of whom were getting a PICC for chemotherapy. They were randomized to receive a PICC either with ultrasound or the blind route, the old way Hochal did it. This is the bar showing complications. The red bars essentially are the blind sticks. The blue are the ultrasound-guided sticks. More red than blue, right? So more complications in the blind group. Notice the center part. No DVT and no phlebitis in the group that got ultrasound. Why do you think that is? It's very simple. It has to do with number of attempts. Right? So with ultrasound, the mean number of attempts is 1. With the blind group, what do you think it was? 3. An average of 3, right? The more you poke the vein, the more it's going to get inflamed, the more you're going to see thrombosis and phlebitis. So hopefully I've convinced you when it comes to ease of insertion, the PICC is your friend, right? It actually does work well. Not just the PICC, but the PICC with ultrasound is standard of care. Let's talk next about thrombosis. And let me begin with a question. How many of you have cared for a patient who's had a PICC-related DVT? Raise your hand. A lot of hands are up in this room. So this is a costly and it's a potentially lethal problem. The challenge is when you ask someone, well, how common is it, the incidence is highly variable. It varies based upon who you study. We know that patients in the ICU and patients with malignancies have the highest rates of thrombosis with catheters. But it also varies on how you go looking. So if you screen patients every week when they get a PICC, 1 in every 3 will have a DVT. They won't even know it, but they have it. You'll see it on ultrasound. And the question is, what do you do with that if they're asymptomatic? Do you leave it alone? Some of us think we should leave it alone. The body clots and lyses all the time. I can tell you as a hospitalist, if I see it, you know what I'm doing, right? I'm treating that clot, and that's not benign because those blood thinners, there's cost, there's risk involved as well. But the rates do vary based upon how you go looking. It also varies upon how you test. So we know that ultrasound is great for arm clots. It's not so good for clots in the axillary and subclavian veins. You can't create great windows there. You can't compress there. So you actually, when you look at studies that use CT, MRI, and venography, much more sensitive and specific for central clots. But here's the kicker, and here's the one thing I want you to remember from my talk today, is that multiple studies have shown that the presence of a PICC is one of the 4 strongest predictors of DVT in the hospital. Now let's just stop for a second. What are the big risk factors for DVT in the hospital? Shout them out. Shout them out. Cancer, good. Immobilization, good. What else? Hypercoagulable state, like they're hospitalized, they're inflamed. What about critical illness and surgery, right? And I am telling you that your decision to use a device in that same condition has the same risk for thrombosis as those other conditions. Hold that thought in your head for 1 second when you think about PICCs. How big is this risk? We looked at this in the literature. We conducted a meta-analysis that we published several years ago in The Lancet. We started off by first looking at how frequent was this event by the patients who were getting these devices. So if you were a hospitalized patient, just sitting in the wards, your risk of DVT with a PICC was about 3.4% in those studies. If you had cancer and you got a PICC for treatment, your risk of DVT doubled from 3.4% to 6.6%. And heaven forbid you were in the ICU critically ill and someone decided that the PICC was the right central line for you, because your risk was the highest at 13.9%. You put them together, the overall risk here is about 4.8%, and you might say, hey, that doesn't sound too bad, right? 96 people don't have problems with it, right? What's the average risk of DVT in a general medical patient who's not in the ICU? It's actually less than 1%. So your decision, again, to use a PICC in that patient population fundamentally changes their risk of thrombosis in a way that something else does not. How big is this risk compared to central venous catheters? Well, we found 12 studies that looked at this head-to-head, compared PICCs to largely acute central lines in the neck and the chest. We put them together. I couldn't believe it. 2.5 times greater risk of thrombosis with a PICC compared to another central line. We have repeated this, updated the literature because there are newer devices out now. There's better technology. That risk is still 2 times higher, even with those new studies, right? These are not benign and not innocuous devices. But look, you and I both know sometimes a patient needs to get a PICC, right? Because we need to actually have access and central access. So what can you do to prevent thrombosis in that situation? There's this concept called the catheter to vein ratio. How many of you even heard about the catheter to vein ratio? A few hands go up. All the vascular access nurses know about this. It's not fair. Let me walk you through this. This is really important. When you use ultrasound, which you should use because it's associated with safety, right? You can actually measure the diameter of a vein. If you throw calipers on it, like you throw over here, that would be about 0.43 centimeters or 43 millimeters. Now, what would happen if you put a PICC into that vein that occupied the entire cross-sectional diameter of that vessel? Where would blood flow in that vein? Would it flow? No. So let me walk you through this, right? So you've got a patient who's hypercoagulable. They're in the hospital. You're going to put a needle into the vein. You're going to cause endothelial injury. And then you're going to put a big tube into that vessel and cause what? Venous stasis. What do you think will happen? We'll have a clot. So the catheter to vein ratio is simple. Never ever exceed 50% of the vein's diameter. Keep your catheter small so there's blood flowing around the catheter every single time. And if you do that, you can know the catheter size, you can know your vein size, you can size your catheter to your vein. In this case, these might be reasonable options. Now, let me give you a little trick surprise here. This is not a human vessel, this is an animal vessel. These studies were done in animal models. We never actually knew whether they worked in humans, but we did it in humans anyway, because that's how we do things in medicine, right? It wasn't until last year that an investigator in Australia, Dr. Rebecca Sharp, actually looked at this in her center. She conducted a small prospective cohort study where she took 136 patients and followed them and looked at those that developed clots and tried to understand what the relationship was with catheter to vein ratio. Mathematically, the model that worked the best wasn't 50%. It was 45%. So you actually do better if you don't occupy even half the vessel. Right? Leave more than half open. The sensitivity and specificity are there. That's not bad for a prediction model. Again, you can size the catheter to the vein. Look, I'm a simple guy. I like simple rules. So if the minimal vein diameter is 3 millimeters, you can get a 4 French PICC. If it's 4 millimeters, you can get a 5 French PICC. You see the math here, right? You can actually do this when you have the vein diameters in your head. And what happens if you violate that rule? What happens if you say, I'm just going to put a bigger one in? The risk of DVT is 13 times higher. Now, for those of you who are statistically inclined, very large confidence interval there. Why do you think that is? Very low number of events in this group. Single study, right? We have continued this work with Rebecca. We're actually doing it here in Michigan. We have almost 6,000 patients recruited. That number is about 10 times higher when you violate that rule. These things matter, right? So what can you do to reduce the risk of DVT? choose the smallest size catheter. It has important impact on a patient's risk of thrombosis. And for your mind, that should be choose a single lumen catheter whenever possible. Every time you add a lumen to your catheter, what are you doing? You're functionally increasing the diameter of that catheter. Your nurses have to find a much bigger vein. Sometimes they will, sometimes they won't. And when they call you and they say, I'm worried about this, trust me, there's a science here. They're not doing this to be difficult. They're doing it because they're protecting their patient. Right? Respect the catheter to vein ratio. So when it comes to thrombosis, the PICC is not your friend. Right? Multiple studies over and over again show this to be true. The risk of thrombosis is much higher with these devices. I know there's some ID docs in the audience. Let's talk about infection next. And for all the house staff, this is required reading. This is Dennis Mackey's work in 2006, where he actually looked at the risk of infection with different IV devices. He looked at the highest quality evidence, prospective studies, and he pooled these data together and said, what is the risk based upon what device you might get? The lowest rate of infection was peripheral intravenous catheters, 0.5 infections per 1,000 catheter days. PICCs, somewhere in the middle, 0.5 to 2 infections per 1,000 catheter days. And those acute central lines, the ones we put in the neck and the groin, highest risk of infection, 2.7 to 3.5 infections per 1,000 catheter days. All right, show of hands. Are PICCs safer when it comes to infection compared to central lines based on this data? What do you think? Yeah. You're not nodding now, but 10 years ago, we were all switching our practice to using more PICCs because we thought they were safer. In fact, hospitals changed their entire policies around using PICCs as a strategy to reduce the risk of infection. There was actually a lot of elegant theories about why this might be true. Let me share a few with them. It might jog your memory about this change in practice. First and foremost, the flora of the skin and the temperature in the arm. Less bacteria there compared to the neck or the groin. Less bacteria at the exit site. Lower risk of infection. Make sense? Certainly thought so at the time. Here's my favorite one, that somehow the longer length of the catheter was protective. True story, maybe bacteria had more to walk down, actually have more space to get there. You can't actually get biofilm as quickly or biomass, and so maybe that's protective. And the third one that I love that comes from the nurses that care for these patients every day is, have you ever tried to keep a catheter in the groin clean and dry and intact, right? It's impossible to keep those sites clean and dry, right? So it's easier to care for the arm. That's why there's lower risk of infections and complications. Now, these are all very elegant theories. We all have heard them, but they were all wrong. Why? Remember who was getting PICCs in 2006? It was patients that Hoshal was trying to get home, right? Patients who were actually able to make that transition. There's a fundamental difference between somebody who's in the hospital still and needs central venous access and somebody who's ready to go home with a device. Not to mention that most of these studies were largely retrospective and had limited data available to actually look at this outcome. So we did what we do well, is we said, okay, let's study it. We did another meta-analysis. We sorted studies based upon where patients were when they got their device. So if they were inpatients and outpatients, that blue diamond there crosses that vertical bar. No difference in the risk of infection between a PICC and a central venous catheter. There was just one very large study by my friend and colleague Nancy Moreau that showed a reduced risk of infection, but the patient never touched the hospital. These were outpatients, right? So fundamentally different patient population than the ones that we think about when it comes to PICCs. And look at the number of studies in the hospital, right? This is where the use of these catheters has really exploded. Put them all together, you actually find no difference in the risk of infection between PICCs and other central venous catheters. All right, this was great. This is 2013. I said, great, we got another paper. This is wonderful. What I didn't expect was what happened next. So in 2014, the Society for Healthcare Epidemiology of America, or the Infectious Disease Society of America, published their updated guidelines for how to prevent CLABSI. And they had a whole section specifically focused on PICCs. Let me read to you what that section says. It says, do not use PICCs as a strategy to reduce the risk of CLABSI. Yes, we were using them to reduce the risk of infection. The risk of infection with PICCs in the ICU does approach that of CVCs placed in the subclavian or internal jugular vein. No difference in the risk between both devices. And then the majority of these infections actually occur outside the ICU, right? It's where PICCs are being used more, in the wards. And that risk is different compared to that in ICU patients. Now, I share this with you only for two reasons. One, because this is largely sort of prompted by work that we did in our group. And so for all of the hospitalists here thinking about a research career, what an opportunity, right, to change practice and policy and guidelines. And number two, this was known to most of us, right? But it took a guideline to actually jump in to change our practice in a very formal way. So what happens then, Dr. Chopra, if I need to put a PICC in somebody who has to go home, right? They need a PICC. I'm going to put it in. It's appropriate. What do you want me to do? The good news is it's the same approach as with DVT. Choose the fewest number of lumens. This is data from the Ann Arbor VA Medical Center. 1,200 veterans who all got PICCs. We followed them over time. We looked at the risk of infection with PICCs, looking at single lumens down here in the blue, double lumens here in the middle, and then triple lumens up top. You can clearly see triple lumens, right? Highest risk of infection. Single lumens stayed fairly low. Double was in between. Now, you might say, well, the patients that get the double and the triples, they're actually very different, right? They're not the same as the folks that get single lumens. This is actually all patient risk. It's not the actual device. Well, we looked at that. We actually looked at everything here in terms of length of stay, whether they were in the ICU, how many times the PICC was adjusted. The strongest predictor of infection was number of lumens down here. So compared to a single lumen PICC, a double lumen PICC has 4 times higher risk of infection. How many of you order a backup lumen just in case? You're shaking your heads, but we all know you do it, right? Think about that when you order that backup lumen just in case. 4 times higher risk of infection, right? And if you have a triple lumen catheter, that risk is even higher. It's 6 times higher. It's simple, right? Use less lumens, all right? So when it comes to infection, I'm going to say it's a wash. The data actually suggests there's no difference in the risk. You should think of them like you think of central venous catheters. Okay? So now I've been thinking about vascular access for a while. The question that I have, that I struggle with every day, is what's the verdict here? Are PICCs really the central venous catheter of the future? Are they the device that we should be turning to actually think about central venous access? I'm going to give you an answer you're not going to like, but I'm going to give it to you anyway, and so hold your breath. My answer is that it depends. It depends on several things, though. It depends on the patient. So you now know that there are some populations that are at higher risk of complications, like thrombosis and infection, than others. It depends on the device. You now know that multiple lumen, that multi-lumen catheter has a much higher risk of complications than a single lumen device, right? And it depends on the providers. You now know that using ultrasound is key to safety with PICCs. Choosing the right device is extremely important when it comes to safety. And then respecting that catheter to vein ratio, really listening to your vascular access team is important when it comes to thinking about catheter size, right? So it depends on you. I mean, you have a role here in terms of safety when it comes to PICCs. But I'm going to say to you, somewhat controversially, that I think, in one word, our current use of PICCs in the US, abroad, is suboptimal. Let me share with you why I'm telling you this and where this data comes from. So I am very privileged to lead a Blue Cross Blue Shield collaborative that has 40 hospitals working together to improve the safety of hospitalized patients. This is work that Scott Flanders did, our Chief Clinical Strategy Officer, and he founded this many years ago. One of the projects here is focused specifically on vascular devices, specifically on PICCs. We look at things like appropriateness, harm, and things about predictors of harm. Let me share with you some data here that I think will make this point about suboptimal a little clearer. This is our first paper that we published from this data set, 10 pilot hospitals in Michigan, where we looked at what was the indication for why the PICC was placed. So let me walk you through the slide here. This is 4,000 PICCs in 10 hospitals. Each of the vertical bars here is a hospital. The height of the bar is the percentage of central lines that were PICCs compared to everything else. So this hospital all the way here, 846, 90% of central lines are PICC lines. This hospital here, all the way on the right, less than half are PICC lines, okay? The colors in the bars represent the documented indications for why the PICC was placed. Now, we don't get this from billing data or coding data. We actually do chart reviews. So this comes from the physician orders, the physician documentation, the IR insertion note, the vascular access insertion note. It's very granular data. So blue is home antibiotics. Red is difficult access. Orange is, I don't know. I can't tell. I couldn't even tell looking at the chart why the PICC was placed, right? And when you look at this data, there's 2 points I want to make about these 10 sites. Number one, look at how the use of PICCs varies, right? These 10 hospitals. You show up at this hospital, and if you sneeze, the chances are you're going to get a line, right? You show up here, it's a 50-50 shot. And then number two, can you find me 2 hospitals that look the same in terms of indications? Right? We laugh and we snicker, but I will submit to you, these are devices with real risks, right? Surely we should be using them in a more standardized way as opposed to what we're seeing in practice. Hold that thought. It's not just about why you put them in, it's also about how long we keep them there. This is data on dwell times, right? So fully 24%, so almost 1,000 catheters came in and went out within 5 days of going in. In fact, over 50% were removed within 2 weeks. Why is that timeline important? Because there may be less invasive, perhaps more safer devices available to you in that short timeline. And you all know about lumens. Let's talk about lumens in these hospitals. So same concept. Each of the vertical bars here is a hospital. Colors now represent the number of lumens. So blue is single lumen, red is double, green is triple. So on the left here, we have that's what we call them, my single lumen hospital, right? On the right, we have my double lumen hospital, a lot of red. And somewhere in the middle, right here, we have my triple lumen hospital, where more than 50% of the catheters are triple lumen. Let's see if you're paying attention. Which hospital has the highest number of DVTs? Shout it out. The one in the middle, right? This one right here. Why? Most triple lumen catheters. Which hospital has the lowest number of CLABSI? 834. These are true. This is true and backed up by data. These choices make a difference to patients, right? You know what the irony is? You know why these hospitals vary so much? It's because the default option was different in every hospital. So the hospitals that use more double lumens, the default was a double lumen. That's all it was. It wasn't a physician making a decision. It was just the way the orders were created. Now, I talk to providers about this. I talk to nurses about this. And like, Chopra, that's great, but we need a method. Like, you can't just say this stuff. Like, how do I do it? Show me how I actually do this. How do I choose wisely? So that method is something that we created back in 2015 that we call the Michigan Appropriateness Guide for Intravenous Catheters, more affectionately known as MAGIC. Thank you very much. What is MAGIC? MAGIC is appropriateness criteria for when you should versus when you should not use a central venous catheter like a PICC. It's created by using the RAND UCLA method, a well-defined methodology that CMS actually uses to make payment decisions. We got 15 of the world's experts together and a patient, put them in the room and said, duke it out. You know what? Because we're not creating a guideline for hospitalists or for vascular access nurses, we're creating a guideline for everyone. Right? So we had first authors of these major guidelines out there. We had eminent clinicians, policy experts. We had IR, cancer docs, hospitalists, infectious disease physicians, critical care doctors, thrombosis experts, not one, but two vascular access nurses, pharmacists and surgeons. Think about your worst committee meeting and think about this. It actually went really well because we handpicked the people that actually worked on this guideline with us as well. And I had the distinct pleasure of writing 677 scenarios for when you should versus should not use a PICC, all the way from a peripheral IV to a port. So for the house staff here, this is not your first research project, okay? This is not what you jump into. MAGIC is all about the PICC. The PICC is in the middle. It's right here, right? But it's not enough to tell a doc that you should not use a device. You have to tell them what they should use, right? So MAGIC compares the PICC in the middle to peripheral devices here on the left, peripheral IVs, ultrasound-guided peripheral IVs, and midlines, to central lines here on the right, non-tunnel central lines, tunneled central lines, and ports. It is the only guideline that I know that covers everything, from all the way from the teeny tiny peripheral to the mighty port at the very end. When we did the ratings, we expected there to be various recommendations. What we didn't expect was that they would be very algorithmic. And so MAGIC is indeed an algorithm for how you choose what device is most appropriate. For example, here are the recommendations for what you should choose when it comes to a peripherally compatible therapy. So let's assume that you've got a patient in the hospital typically for less than 5 days. On the top here, you have your duration of infusion, 5 days, 6 to 14, 15 to 30, more than 31. And on the left, you have all of your devices listed. The green bars are what are appropriate. So those are devices you could use for a peripheral infusion. Notice where the PICC is. Not appropriate to use a PICC for a peripherally compatible infusion for less than 5 days. That's not just us, also CDC. And yet what I just showed you was that a quarter of those devices were in for less than 5 days, right? MAGIC also works for vesicants and irritants, things you should not infuse through a peripheral vein. All the peripheral devices go red now. You shouldn't be using those for anything like that. Notice, though, that there are preferences, especially in the ICU. We do request that you use central venous catheters in the ICU. There's a lower risk of thrombosis. And then the PICCs are appropriate at all durations. The beauty of MAGIC, and the area where I think it really makes a difference, is down here. So if you've got a patient who's coming in every other month for chemotherapy or cyclical infusions, the PICC every 5 days is not a good choice for that patient, right? That's a patient that probably needs something a little bit more permanent, like a port or a tunnel catheter, right? So MAGIC forces you to think about these devices that you ordinarily may not even think about, given the risk of the patient and the nature of their therapy as well. Does it make a difference? Does it work? I'm going to start with an outside hospital in Michigan, an OSH, not us. This was a QI project that was designed by the vascular access team at an outside hospital. They use MAGIC for one reason and one reason only. When should we use a PIC and when should we use a midline? That's all they wanted to focus on. They looked at two criteria on MAGIC, the duration of use and what you were trying to infuse. And if you didn't meet the criteria for a PIC, you got a midline. It's a simple algorithm, right? Now, physicians don't like this, obviously, because I want what I want. So they actually had a physician champion on the back end to support them. That physician champion was the chief quality officer. So Dr. Bernstein, I know you're here. You might be pinged for this moving forward. Here's what happened to this hospital. This was published in BMJ Quality and Safety. You can see here that this hospital had a problem with PICs. Their use was increasing dramatically. The black bar is where they intervened. Here's what happened after they intervened. They had a 30% drop in their overall use of PICs. Here's what happened to the midline data. You can see here they weren't using a lot of midlines. As they implemented, their use of midlines went up dramatically. So they were shifting people to a different device for shorter durations. They also changed the way they were using their PICs. So here's data looking at the number of lumens in the catheters and the number of PICs placed. So 100 to 120 a month in this small hospital. You can see the majority of them were blue and orange. That's basically double and triple lumen catheters. Not a lot of green, not a lot of single lumen. I'll let you think about where they might be on the charts I showed you a few slides earlier. They weren't doing well, let's say. After implementing MAGIC, their use of PICs dropped, as I showed you. But look at the green bars. Look at what was happening with their decision making, right? Almost half of their catheters flipped to becoming single lumen catheters. Did this make a difference to patients? Here's their data from DVT rates. These are hospital-acquired upper extremity DVTs not present on admission. They had about 1.3 per thousand patient days. They implemented, their DVT rate dropped to 0.77 per 1,000 patient days. Now, we at Michigan, we're good about innovating, but we like to come second so that somebody else tries it and then we can do it ourselves. And so we have a wonderful hospitalist, David Bozan, who said, you know what, I'm going to do this here too, but I'm going to do it a different way. I'm going to start by educating the providers, because we're an academic medical center, about the importance of lumens, and I'm going to do it in a fun way. I'm going to give everyone little bands that they can get if they come get their education. Now, here's what the bands actually had. These little blue things that said big M on it. We all love our block M pick. Less lumens, less risk. Have you ever seen people chase someone for education? This was happening because everyone wanted these blue bands, right? Everyone had one. Where'd you get that from? Oh, I want to get that too, right? So Dave ran out pretty quickly. That was phase one. Phase two was by another one of our hospitalists, David Pahe, who's here as well, who we actually work with to change our order sets. You may not know this, but the EPIC order set you see today was not the one that we had many moons ago. It's been changed, and it incorporates a lot of the MAGIC criteria within. So there's indications that are standardized. If you choose anything but a single, like a double or a triple, there's a cascading box that opens up that asks you to say, why are you using that? What is the indication for that? We created these, by the way, working closely with pharmacy and vascular access teams, so there would be no confusion around what was appropriate here. And then the nice thing about this is it creates a paper trail. So physicians that don't behave or don't follow the rules, when your order is next to that name, somewhere in there, I will find you, right? We actually had great support from pharmacy and vascular access as we rolled this out. Let me show you what happened at our hospital medicine group. This is looking at our rates of single lumen catheter at Michigan Medicine. We did fairly well here. You know, this is the home of MAGIC. A lot of single lumen PIC use, but you can see the blues and the yellows. Still a lot of double and triple lumen catheter use. Phase one was just the blue bands. Everyone got the little big block M's. Here's what happened. Rates went up a little bit. The major impact was on using less multi-lumen catheters. And the lesson here, by the way, is education is great, but education is never enough. You need more than just education. Here's what happened when we fired up the EMR, right? And this is why our rates of single lumen use in Michigan today are actually quite high. We have very complex patients, right? But we're able to do it working together with pharmacy and vascular access in terms of what patients may need. Does it matter? Let me show you our data. This is the data that we collect from HMS looking at the numbers of CLABSIs in Michigan from PICS. Around here is when we actually launched MAGIC. So you can see that the rate was kind of not looking good before. Here's what happened afterwards. Now, I'm not saying this is causal. I'm not saying it's all because of our tool. But I'm making a point, right? That it actually does change the way we think about ordering practices. It's not just CLABSI. It's also deep vein thrombosis. Same approach. This is when we actually were working on the order set. Here's what was happening before. It was not going the right way. We built MAGIC. Here's what happened afterwards. Rates went down. They continue to go low, by the way, at Michigan as well. Now, look, we got to go beyond the ivory tower, right? It's great that we're doing this here. We got to go beyond that as well. With our Hospital Medicine Safety Collaborative, we've been doing this work across 48 hospitals in Michigan. This is our most recent data. 36,000 patients, all of them have gotten these devices. The rates of single lumen catheter use are close to 75%. When I travel around the world and I talk about our work, I say if you come to Michigan and you come to one of our hospitals, there's a 3 in 4 chance you're probably getting a single lumen device if you need one. Something I'm very proud of. This is the rates of double lumen going down, and this is the rates of triple lumen catheters also going down. This is a significant change from when we were a few years ago to where we are today. This is wards. Let me show you the ICU. So in the ICU, something very different happened. We started to see an increase in double lumen catheter use and a decrease in triple lumen catheter use here in the green bar. In fact, the single lumen catheter, who would have thought in our ICU we would actually place single lumen catheters, went from 5% to 12.4%. I tell you this now because how do you make an ICU nurse really mad at you? You say single lumen pick. They don't like that, right? And yet we're able to do it. Miracles can happen. Why does all this matter? What's the point of all this work? It's great to show you the numbers and the data. Let me make this very real for you. Each of these outlines here is a patient that would have had a DVT had we not done this work. It's 179 patients who have not had an upper extremity DVT compared to when we first started because of the work we're doing around process improvement. For those of you who are interested in the money aspect, it's about $11,000 a clot. This is about $1.9 million in savings only by choosing a different catheter. It's a fairly simple yet fairly powerful intervention. We're doing this across the country. This is the largest VA in the country in Houston. This is their data. You'll see their gray bars here are PICCs. They're using very few PICCs. They're using much more peripherals. And I got a wonderful email from this person a couple of weeks ago that I'll share with you today. Here's what he said. Just to let you know that since we fully adopted Dr. Chopra's magic algorithm at this VA, we have eliminated 50% of unnecessary PICCs on the floor that can be potentially infected. It's wonderful to see that, right? Like the work is really making a difference. It's happening all across the country. These are hospitals where magic is either the protocol, the algorithm, the guide, the policy for vascular access decision making. There's still some holes here. I have some places I have to go visit. But you can see that the diffusion is real. It's not because of magic. It's because there was a huge need for something like this to help make decisions. It's actually happening all over the world as well. I just heard that the NHS in the UK is going to adopt this as one of their criteria for performance. So we're going to see this actually go beyond the US in a policy way. So how can you apply magic? How can you do this yourself? Well, there's an app for that. So this is the part where you take out your cell phones, everyone. If you don't have the magic app, take them out, point that to the QR code. And if you're on the iOS software, this should take you straight to the magic app download. If you're on Android, just look for Michigan Magic. You'll actually get the app on your phone. None of the vascular access nurses are doing it because they already have the app, by the way. And so what is the Michigan Magic app? It's quite simple. It's actually an app that shows you the big splash screen, walks you through the questions with magic. What are the following indications are you ordering a PICC for? If you say IV antibiotics, the next question is, have you talked to ID for approval? True story, everywhere I go I hear this, right? If you think about all the IV antibiotics we use, about a third of patients don't even need antibiotics. About a third could potentially be oral antibiotics, and about a third actually need the IV, right? This is true no matter where I go, and I think it's probably true in places here as well. So once you get ID approval, the next question is it actually something you can infuse peripherally? No one knows that, so there's a list there for you to click on, gives you the answer you need. The next step is how long are you infusing it for? It's the magic algorithm, the duration, and then out pops your appropriateness criteria. Ascension Hospitals, which is a hospital system, about 600 hospitals or so, have made this mandatory before they actually order a PICC in their hospitals. So the nurses actually do this, and if it doesn't fit criteria, there's a question as to why we're using the catheter this way. Now, a new app is coming soon, and I'm really excited about this. It has chronic kidney disease in the algorithm. So we know that we should not be using PICCs in patients who have chronic kidney disease. The app currently doesn't have that. The new one will. We have a better user interface. You can see where you are on the algorithm, so you don't get lost in terms of where you are in the tree. We have a specific section for TPN, so there's a nutrition section for what you should do with those patients. And what I'm most excited about is when you open the app, it'll ask you, are you a patient or are you a healthcare provider? And if you're a patient, the options there include, why do you need a PICC? Questions you should ask your doctor before you get your PICC. And there's videos there for how best to care for them. when you're at home or when you're in the hospital. So this actually will be a very powerful patient education tool as well. But let me go back to our case. Remember that guy in the ICU that I was asked to see at the very beginning, how this whole story started, right? So a 68-year-old male with diabetes, hypertension, pancreatic cancer in the ICU, high risk for thrombosis in the ICU, right? Was on TPN. My first question to the fellow was, how long do you think you'll need TPN? So, well, probably weeks. I said, okay. By the way, they had ordered a PICC for this person at that time. This person ended up getting a tunnel catheter. 62 days later, the catheter came out and the patient did really well, right? So this has important impact on patient care. Think about this the next time you're ordering an IV device. I'm going to end. I want to acknowledge a number of people. This work is not possible with one individual. I have a wonderful team of collaborators, advisors, the HMS team that does all this work. They are the people that make the magic happen, quite literally. We have a wonderful research staff, and we have great global partners that are doing this work across the pond. I also want to shout out to my vascular access team. This stuff is not taught to us in medical school. I have learned a lot of this from them. So we have the best team here at Michigan and at the VA. So please listen to them. They actually know what they're talking about. And last but not least, to the best division of hospital medicine in the country. It is a privilege to be part of this team, and I'm grateful to be here. Go blue or go home. Thank you very much. I think we have time for questions, right? Great.
Vineet, it's always a pleasure to have you. We have open for questions. Maybe I can start out with one. You mentioned a couple of consequences of having a PICC, and so you have to be careful and think about those things, and you showed a lot of data in that regard. I was wondering, just for clarification, the risk for DVT is obviously highest in the vein that the peripheral PICC goes through. Is there any risk for DVTs elsewhere with that type of PICC? I know the central lines, it's usually in line as well as PICC, but is there any other evidence for any spread? Because I know it's the phlebitis that drives it.
So the question Dr. Carruthers asked is there risk for DVT elsewhere? What is the actual implication of that? So upper extremity DVTs behave very differently than lower extremity DVTs in a number of ways. First and foremost, they're less symptomatic, so you may not know you have them. When you have leg clots, you tend to actually have pain. You don't in the upper extremity. Number two, they are very related to where the vein and the catheter are, but they propagate. So they don't just stay there, they actually move more proximally. So if you have a person who has a thrombosis and you don't give them anticoagulation for a reason and you screen them every week, you'll see that clot expand more proximally. But strangely enough, and we don't know why, they don't break off as much. They don't actually cause PEs as much. What we found, interestingly, was when you think about thrombosis, it's actually a systemic process. So even though you have a local clot, you're revved up with your D-dimers, we've actually found that patients who have upper extremity DVTs are at higher risk of developing a lower extremity DVT. So in fact, what happens is that we think you actually trigger the thrombosis cascade. You have a clot here, and then they're sitting there waiting for something to get them fired up and inflamed, and they develop lower extremity clots too. We haven't seen the reverse association, so if you get a lower DVT, do you actually get more risk of upper extremity DVTs? I think in part that's the way we sample. We don't sample those patients as well. But if you think of thrombosis as being systemic, fairly confident you'll see an association not just in the arm, but also in other sites as well.
I have a
question. I think that we're doing a really good job when it comes to trying to avoid a patient getting a DVT. But one of the frustrations with our team that we see a lot is, and this happened a couple weeks ago, say a patient comes into the emergency room, and my arm feels heavy, there may be even a little swelling in the arm that has a PICC. Patient got a upper extremity DVT scan. They have a partially occluding thrombus in the basilic associated with the PICC line. The knee-jerk reaction is, oh, we have to take the PICC out and put it in the other arm. Same patient, they did that, and we really recommend against that because we go by the chest physician guidelines that say if there's an ongoing need for a central access, keep the central access. And even with a thrombus in the basilic, that you don't even have to treat the patient for that. So the patient comes back in not even a week later and has a DVT now in the other arm that involves the axillary and subclavian vein. And this is something that we're very frustrated with, and we've been trying to educate the providers if there's an ongoing need for access, please leave the line, and if clinically indicated, treat the patient. Don't take the line out and put it in the other extremity.
Yeah.
And I wanted your thoughts on that.
Yeah, no, that's a great scenario, and I'm sorry to hear that's been happening. So let me take a step back. If you think about people who've had a DVT in the arm with a PIC, the relative risk of another DVT within the first 30 days is incredibly high. It's in fact one of the most powerful predictors of recurrence, because what you're doing is taking someone who already has the thrombotic cascade activated and putting another endothelial injury, another stick in the opposite arm. So what do the chest guidelines say? There's 3 questions you should ask, right? Number 1, do you still need central venous access? If you need central access, number 2, is the catheter tip still in the right place, right? Because we know when the catheter tips move, they go higher up, they're at a higher risk of having deep vein thrombosis. So you got to check your catheter tips to make sure they're there. And number 3, is the PIC still working, right? Because if you've got this ball valve thrombus sitting at the end of your line and the PIC is not working, you're not going to get much out of that device. If any of those 3 criteria are met, then you leave the catheter where it is and you anticoagulate. You should not put another catheter in. That's in the chest guidelines. It's actually part of the educational aspect. I feel your pain. Not a lot of physicians know about this. On the other hand, if you can't anticoagulate, or if the patient has, thrombocytopenia or a risk, you can't leave that catheter in there, because all that will happen is it'll propagate. But I think the key thing to think about is, number 1, do I still need that line? It's almost this sort of like reflexive aspect of replacing as opposed to what am I going to do with that other device? And then number 2 is the increased risk you have, which you've got to take into consideration. I think you should think about thrombosis like you think about infection. If you have infection, the ideal thing to do in certain conditions is to remove the line and give them a line-free holiday. It's the same thing I think about with thrombosis. The question you should ask is, do I still need that line to be in place as well? As for how long you should anticoagulate, that's a bit of a controversial area. We don't know for sure in the upper extremity. We think it's at least 3 months, but there are patients where the line stays in beyond that, and recommendations which are largely based from observational data. So just keep anticoagulation going until that line is removed, and then there's some controversy as to whether you go beyond that or not. But in general, once that line is out and 3 months are up, you can actually get rid of the anticoagulation. But it's a great question.
Thank you, Vineet. This was riveting, and I must admit I was thinking it's going to be a boring talk, but you managed to make it amazing.
Thank you for your honesty, Aleda.
So I had a quick question about duration. So you showed us amazing graphs focused on overall outcomes. Do you think they vary looking at 10 days in, 20 days in, or whatever milestones?
It's a good question. So the question was, do outcomes vary based upon duration? They absolutely do. So the one thing I didn't highlight here, most deep vein thromboses happen within the first 72 hours of a PIC going in. It's an early sort of first spike, and then there's a linear upward trend until you get to about day 12, day 13, where it starts to pick up again a little bit. It's not a linear line. There's a large number of events that happen early, and they happen early because I think you're not respecting the catheter to vein ratio, or you're causing local inflammation. Those events are very distinct from other events. CLABSI, on the other hand, was also thought to be one of those things that happens over time. And a lot of the functions that we had in mind were linear. The longer the line, the higher the risk. Turns out the decision to choose a single versus a double versus a triple influences the slopes of CLABSI within a week. So by 7 days, your decision to use a double lumen catheter has fundamentally changed the risk of an infection in that patient as opposed to using a single lumen catheter. We still will detect them much later. The slope is not linear. It actually is kind of J-shaped. So it starts off low and then it starts to really pick up after day 14, day 15. A lot of factors there with respect to how the line is inserted, who's caring for it, whether it's a single or a multi-lumen catheter. But the point is, those decisions have very early impact. And for thrombosis, it's within days. For CLABSI, it's within a week. So it's actually very time varying depending on the catheter as well. So it's a good question. Steve.
Vineet, you showed us data earlier about the risks for thrombosis, infection, etc. Many of those studies were before we knew about the ratio of lumen catheter. I was just wondering if you feel confident in the conclusions that you reached, given that we now know far more about those types of issues.
Yeah,
and
that's
how
a
we
great
manage
question. So when we updated the meta-analyses, we looked at studies published after 2014 that we did not include in our original analyses. We continue to see that twofold higher risk of thrombosis, even with modern catheters today. I think if you think about the ratio, it's actually not so much knowing about it as it is actually applying it. I see this happening in hospitals everywhere. They know what the right thing to do is, they just don't do it. because they want more, a double lumen just in case, that type of thing. So the trick is implementation, is how do you actually get this to be the rule and have it to be what happens with patient care. So I think if you do it right, you have lower risk, but I don't think that people are doing it right everywhere. It's a good question.
Oh.
Have you noticed a reduction in the number of PICC lines in for 7 days or less? Because I would think those would generate a lot more revenue for a hospital than a peripheral IV.
It's a good question. So the question was, have I noticed a decrease in the number of lines placed? Absolutely. It's one of our key performance index criteria for hospitals that participate. And the performance index is how many of your PICCs are less than 5 days, where devices could be differently used, perhaps. In terms of revenue, it's actually different. So on the inpatient side, a lot of that revenue is built up into the DRG. So it's not actually something that drives the bottom line as much as the diagnosis-related groups for why a patient comes in. You think about these patients, they're either getting PICCs for long-term antibiotics like osteo, or they're critically ill, or they need TPN. There's a lot more that drives the cost than the catheter. On the outpatient side, you're absolutely right. In fact, some of our hospitals will place a PICC in the emergency department where patients are still considered outpatient because you get paid 3 times much more than the inpatient insertion, and then we'll admit the patient for chemotherapy in the next minute, right? So there are these games that places play, but I will tell you, one CLABSI negates all of that, right? The cost of a CLABSI is so sort of high, not to mention the impact on reimbursement and payment for that case, that hospitals are being much more mindful now of what they're putting in at the very outset. So it's not so much a revenue question as much as it used to be anymore.
Vineet, I think the hour's up, so thank you very much. That was a very informative, wonderful talk.
Thank you.
And I also want to congratulate the students again.